We'll just start right here. Systematic review, meta-analysis, and meta-regression. But first, a little bit. Today, we'll talk about the predictors of adherence in e-health for substance use. I will first take you through the literature, the current literature that is out there in regards to adherence in e-health for substance use. And then I'll share the findings of our systematic review, meta-analysis, and meta-regression. But first, a little bit about me. My name's Farhud, and my background is actually in computer science. So I did my bachelor's of science and engineering in Austria, and then moved on to do my master's in experimental medicine, which I am finishing up right now with this work. I work as a graduate research assistant at the Addictions and Concurrent Disorders group at UBC with Dr. Michael Cross, and my research focus is on e-health interventions for mental health and substance use. I also work part-time as a data analyst, and I have professional experiences as an IT consultant. I have no conflicts of interest to declare. So let's get into the topic. First, I want to talk a bit about the background and the current literature. So as most of you probably know, e-health interventions have shown promising results in terms of their effectiveness for substance use disorders. The majority of studies that are actually out there, they focus on alcohol, nicotine, and cannabis use. There's a few studies that focus on opioid and stimulant use, but I haven't come across any reviews, for example, in that domain. Adherence and dropout are two concepts that are commonly reported to be an issue with e-health interventions. So low adherence and high dropout lead to interventions not really being used, and so their effectiveness can either not be measured or it will not it will not be reflected properly. Eisenbach, the founder of JMIR, published a seminal paper in 2005 called The Law of Attrition, in which he argued that there is a need for a science of attrition in order to more effectively understand and measure the factors that may lead to attrition. So attrition is a concept that is very closely related to adherence, but there is a lack of agreement in the literature regarding the definitions of adherence and related concepts. We'll get to that in a second, but it's important to understand the predictors of adherence as they may lead to insights for future intervention development. So what is adherence in e-health? Adherence usually refers to the extent to which individuals experience the content of an intervention. It may be measured through something like the number of modules completed. There are many related terms, one of them a common one being dropout or study attrition, which refers to the percentage of participants in a study who did not fulfill the research protocol. Now, there is a difference between dropout and adherence, because in dropout, we are not really focused on the usage on the user using the intervention itself, but it's more about them just finishing the final questionnaires in the study and fulfilling the research protocol, which means that the dropout numbers don't really reflect how the participants actually engaged with the content. Now, staying engaged with the content and measuring that is obviously very hard because it's very subjective. We can't be in the participants' minds or look through their eyes, although there are methods to measure that. But that is a domain of research that is very deep in computer science, and it's just not very cost effective. So for us, we want to be looking at simple objective measures of adherence, and one of them would be the number of modules completed. Another related term is retention, which refers to the percentage of participants that remained in the study. It's basically the inverse of the dropout or study attrition. The next term would be user engagement. User engagement in itself is actually a word that is commonly used when we talk about this topic, but it's a very vague one. And in the literature, it's actually not used as often, especially in the health literature. User engagement, the term actually comes from the computer science literature and describes a specific experience of end users of technology. So user engagement is not really focused on health. It's more focused on technology in general, and it contains very subjective measures like the effect of the participants, sensory appeal, challenge, and these kinds of things. So tracking eye movements, that's something that would probably fall under user engagement. Usability describes some specific characteristics of interventions, e-health interventions, for example, ease of use, and it's usually rated as some sort of qualitative metric, qualitative in terms of like what's the quality of the intervention, like are the buttons big enough, is the font size easy to read, but it's usually very subjective measures. So there's just like a feedback form for the participants to fill out, and it may be a factor that predicts adherence, but it's not really saying anything about the usage itself. Other related terms may include satisfaction, compliance, uptake, trust, etc. So I'm just going to pause here for a second because this is very central to this topic are these different definitions. So if there's any questions right now or any comments, are there any other terms you might have heard about or any other definitions even of the terms that are in here? We'll just wait a minute and see if someone has a question. So one thing I wanted to add here is that usability. I mean, I said feedback form in the presentation, but there's actually a few standardized scales that rate usability based on set factors, but it's still subjective because there's a system to rate it, but it's not as objective as a measure as, for example, the number of modules completed. So that's why, yeah, that's why the difference in the terms and definitions. Parsa, are you actually, is there any question on Huva? Because I'm only monitoring the Zoom chat right now.
Yeah, I checked Huva. At the moment, I don't see anything. So I think we should be good for now.
I'll take that as a good sign then. So let's take a look at the current state of literature. So right now, there's a few reviews that have been published, and they've been looking at adherence from a few different angles. Some of them are very specific. For example, they look at a certain type of intervention, like online CBT, or a specific population, like youth, or even a combination of those. Most reviews do use a very specific definition of adherence, or they may be looking at one of the related concepts we just talked about. One of them that is very common is obviously study dropout, which might still be interesting for us because there's a few insights that we can take from that. For example, one of the specific definitions of adherence, or actually a utilization of how to measure adherence, is the number of logins or pages visited on a website. But again, if you think about it, this is not a great measure to actually tell if the participant was experiencing the content of it. That just means they opened up the website or they logged in to the website. In 2017, Siverink set out to shed a light on the concept of adherence in e-health. And they came up with, so this should actually be saying Siverink et al. Sorry about that. So this study looked at adherence in e-health in general and try to just come up with a clear framework and understanding of adherence that can be used in the future. And one of their conclusions was that adherence is very underdeveloped as a concept in the e-health domain. And one of their other conclusions was that one important aspect that is missing is the intended use, which can also be described as a kind of a recommended use. Either that is missing or a justification for it is missing in most studies. And intended use is important because it allows us to model a dose-response relationship. If you think about medication adherence, there's always a dose specified. And so modeling a dose-response relationship becomes easy once you track the participants' adherence to the medication. So this is something that they recommend e-health should try to strive towards. Yeah. So yeah, this is actually the interactive part because I'm interested to know before we actually look at the literature and what's out there currently in terms of characteristics of studies or interventions that may influence adherence positively or negatively. I would like to know if there are any ideas here or if there's any experience with that. Obviously, I'm not sure if the participants here have been looking at the literature of adherence, but just thinking about developing some sort of health intervention, let's say specifically for substance use, what would be some factors that may benefit adherence? Maybe just put them in the chat and we'll talk about them. If anyone wants to unmute themselves and ask a question or comment, feel free.
So Anna mentioned access to equipment.
Yeah.
Yeah, and also we have Arena who mentioned reliable and constant access to the internet or device. Also, as we can see, we have Anna mentioning again space to do online content.
Yeah.
Yeah. So there's a bunch of comments that just came on, but yeah, I mean, Farhud, if you want to take a stab at any of those, please feel free.
Yeah, just all right. So this is actually really interesting. Yeah, so let's take a look at the next slide and what we have in the literature. And there's actually an interesting contrast to the current opinions in the chat. So what are some of the factors predicting adherence that we can find in the current literature or in the current reviews? So unfortunately, there are no adherence reviews that specifically or exclusively focus on substance use. Most are just focused on behavioral interventions in general, or sometimes called e-therapies in general. Many reviews looked at dropout attrition rate versus actual program usage, but as I mentioned before, these insights may still be interesting for us to create hypotheses for adherence factors, or factors that may predict adherence. So according to the literature, some of these factors are higher treatment expectancy, credibility. This basically means that when a participant expects that an intervention is effective and credible, their adherence is higher, and most likely also the effectiveness is higher. But again, this is a very subjective measure. So this really is patient feedback kind of a measure. The same thing applies to sufficient time availability. So in one of the reviews, participants, or in one of the studies that was included in this review, patients reported that they didn't have enough time to complete the intervention. Again, a very subjective measure, and something that is obviously not commonly reported. So it would be hard to do any kind of meta-analyses on that measure. Another interesting and I think heavily discussed predictor of adherence may be personalized intervention content. For obvious reasons, if the intervention content is tailored to somebody's needs, then probably both effectiveness and adherence will go up. Another very commonly discussed topic is guidance or social support. There's actually, out of all these factors of adherence that I've seen in the literature, guidance is probably the most hyped, let's say. Yeah, guidance or social support. So this could include a lot of different things. And the problem with that is that most studies in their methods, most experiments do not specifically describe how the guidance was provided, what the training of the guides was. Sometimes it's not even clear if the guides, or I'll just call them guides here, are clinicians or non-clinicians. So that's one part of it. There's also peer support, which interestingly enough, in the current literature of substance use, so e-health for substance use, I've come across rarely, especially when it comes to adherence. So it's actually not included in this work that I'm going to present in a bit. Phone support is another form of guidance. Again, obviously, it could be a combination of these. So clinician guidance could be over the phone, or other combinations are obviously also possible. And another factor that is also interesting are reminders and notifications. So the most common one in the literature right now is email reminders. Notifications are still relatively new and they haven't been analyzed very often. So yeah, based on the comments, I just want to look at this list of the discussed factors that I found in the literature. And it's interesting that when we think about adherence and improving adherence, especially in substance using populations, a lot of people mentioned access to equipment, access to a device, access to Wi-Fi, and just available resources. And it's, so from my experience, looking at the literature, this is actually something that has rarely been looked at. There's a few studies discussing it, but there's far from enough to do any kind of review and draw firm conclusions from it. And usually, again, we're looking at very, very subjective or qualitative data when it comes to that. We can see some of the other factors that are mentioned here, those were also mentioned in the chat, such as personalized intervention content. So we have literacy level mentioned here as well. I think that would fall under the umbrella of personalized intervention content, so tailored content. I think this is, as I mentioned, it's heavily discussed and it's often mentioned as important. And if we look at studies that actually look at describe the development of interventions, this is something that's mentioned over and over again. But unfortunately, there's not enough measures and metrics to, again, do any kind of analysis on it to be able to draw firm conclusions. So it's a lot of it is just based on qualitative feedback from participants or even the study staff or the physicians that provide the care or support the treatment trajectory. So unfortunately, looking at education levels, I've seen a few studies, but far from enough to include it in any kind of analysis. And especially in the substance use domain, there's very few. So this is a huge gap, and future studies will definitely need to address this a lot more. Yeah, another thing that's mentioned is reminders. So as I mentioned, notifications, they're been rarely looked at so far. I think it would be very interesting to see more studies focusing only on smartphone apps. There's one review that I came across. It was interesting, but it's it's still very young, the area, I would say. So there's not a lot of the possible factors haven't really been looked at, and the correlations are not clear, and the mechanics of, or the mechanisms of how it will work, and if there's the difference, for example, between an email reminder or a phone call reminder and a notification. Yeah.
Okay, Farhad, there's a question that is discussed in the UVA. Would you like to address it right now, or you want to wait till the end of the meeting?
Sure, if it's regarding the factors predicting adherence.
Yes, I think it's relevant. So here we have Taylor asking what kind of reward contingencies are in place with e-health resources that reinforce clients' e-health utilization behaviors.
Okay, so can you repeat that again? I'm sorry.
Of course, yes. So Taylor is asking what kind of reward contingencies are in place with e-health resources that reinforce clients' e-health utilization behaviors.
Ooh, that's a good question. But also really tough to answer. So if I understand correctly, we're talking about, in a way, about the perceptions of e-health and just the overall readiness to try e-health interventions. Is that, am I getting that right? If someone can interact with me here.
I think so. I think that's what Taylor is like intending right now. I mean, but I again, you can feel free, Taylor, to either put it in the chat or even like unmute yourself if that wasn't what you intended to ask.
So if we can get a clarification, I can actually get back to this question. But it sounds to me it would fall under perceptions of e-health, and it's kind of a separate area of research, I would say. But again, let's just get back to it during the QA session. We'll just continue the presentation.
Oh, actually, Taylor is here. I think she wants.
Yeah.
Oh,
I can hop in and give a bit of a
Perfect.
clarification. Can you hear me?
Yeah.
Yes.
Yeah. So what I was asking is, when people are using the, I guess what I'm wondering is like, are there any short-term solutions that come up for them with the e-health resources, or is it really sort of just focused on the problem of, say, addiction? Because if the goal is to get them to, say, use less, that's something that could happen over a long period of time. And I'm wondering, what is the user getting from these resources the first time they use it, the second time they use it? Like, what are they getting from it in the short term that's going to have them keep coming back to the resource?
Yeah, that's a really good question. The issue here is that most studies, they're obviously their main outcomes of interest down the road are the long-term or even short-term substance use reductions. So they're looking at, I don't know, when we're looking at alcohol, just the number of drinks. And a lot of studies do have actually good results in terms of reducing the amount of substance used in a duration for, like, let's say 30 days. And that is one reason why we're looking at adherence here, because it may be outcome measure that kind of sits in between here for the short term and might reflect how people are experiencing this content, and if they're actually engaged with it, and if they feel like it's helping them. But I can say that there's not really a lot of outcome measures that are focused on the first session or on like some really short-term kind of variables that may predict other outcome variables in the long term. I think this area is just too new to look at those variables. Right now, the main focus is just on reducing substance use, obviously, as fast as possible, but they're usually long-term variables. I don't know if that kind of answers your question here.
Yeah, as best as you can. I mean, you can't get an answer when there's not enough research to answer the question with. So I appreciate that.
Okay, thank you. Let's continue so we can stay in our time frame. I think reminders and notifications, one might argue they could also fall under the umbrella of guidance. So now we're going to go into our systematic review. So the objectives of the systematic review was to look at the literature of e-health for substance use, to first of all pull the existing rates of adherence using a meta-analysis. So this is a single group meta-analysis, but because when we're looking at adherence, we usually don't have a control group, so we can't really calculate an effect size. The second objective was to assess the predictors of adherence using meta-regressions. And for that, we have hypothesized a few predictors to look at in advance. So which measures of adherence are used in this review? There are two adherence measures that we were interested in, and a quick literature review revealed that these are probably the most consistently reported ones. The first one is the mean number of modules completed. It's important that we're not talking about modules or sessions that have been started. So this is actually not always easy to find out, because some of the studies mention that X number of participants attended this module session, but that does not necessarily mean that they completed it. And most of those studies do not provide further detail. So we actually excluded those. The second measure is the percentage of participants that completed all modules. So ideally, because we talked about the intended or recommended use earlier, this measure should have been the percentage of participants that completed all recommended modules. So basically adhere to the dose. And then we would be able to look at the dose response relationship. Again, a quick literature review early on revealed that those kind of studies would be really hard to find. So we just decided to go with all modules. Why are these measures good? Or why did we choose these measures for a meta-analysis? First of all, they're objective measures and they reflect the use of the content. Again, if we compare it to dropout, we're looking more at the study level and not an intervention level measure. They're regularly reported, and thus they may be used in a meta-analysis. So the limitations, like I just said, some of them report attendance and not completion. Standard deviation and total number of modules are not always reported. We have to consider that many of these studies, for many of these studies, adherence is not really a primary measure. So it's just kind of something they report on the site. So there's a lot of information that goes missing. We tried to contact as many authors as possible to get the data, and here and there it worked, but it's not always possible. Yeah, and another limitation is that there is no reporting for these variables in the control group, like I mentioned before, so we can't really calculate an effect size. So when we look at the hypotheses for predictors of adherence, we came up with 4, and one of them is actually split into 2. So let's just go through it. The first hypothesis was regarding guidance. As I mentioned earlier, it's a very, very popular topic of discussion to talk about guidance and different forms of guidance and how it might increase effectiveness or adherence to e-health therapies. So that was the first measure we wanted to look at. So the first hypothesis is that any guidance is basically better than no guidance and leads to higher adherence rates. The second hypothesis says that the clinician guidance compared to non-clinician guidance leads to higher adherence rates. And later we'll see how we fit that into a regression model. The second hypothesis was that treatment was blended, yes or no. So blended treatment basically means that the online component is actually an adjunct to some form of treatment as usual. So this could be substitution treatment, for example, or it could be face-to-face therapy that is going on in parallel to providing the online or e-health therapy. So here, the hypothesis was that blended treatment leads to higher adherence rates. The next hypothesis is recruitment. So here we're looking at the type of recruitment. It could be local or global. The definitions are that local recruitment includes anything basically where the study team approaches participants, for example, in clinics or in their local area, maybe through local newspaper ads or calls, but they get the contacts through some sort of related clinic or health center in the area. So most of the time, actually, in our review, 100% of the time, this means that the study team actually approached the participants in a clinic or treatment center or some sort of facility. And so the population is very specific usually, and there's a few reasons that why a local type of recruitment could lead to higher adherence rates, and that could be accountability because of the personal contact, for example, or just because the content is better tailored to that specific population. Global recruitment would basically be any type of recruitment done through the internet, through widespread social media, like on Facebook, or when participants are recruited through a platform like the Amazon Mechanical Turk, where you can just put up a survey or an intervention, and it's accessible to a wide variety of people. There are ways to filter, even on a platform like that, but the likelihood that it will only cover a specific population is very unlikely. The last predictor we looked at, because it's an interesting one, and in the literature it has been suggested that intervention duration may intervention duration in weeks, it has been suggested that both longer and shorter interventions may actually lead to higher adherence. So the findings have been very mixed, and we thought it would be interesting to look at it in our studies and see if we can find any any tendencies here. So just quickly going through the methods, we used a basic search strategy on 3 databases and included peer-reviewed literature from 2009 to basically end of 2021. So you could say current. The study selection was based on a typical 2-step process. So we have the title, abstract, screening, and the eligibility phase where we did full text reviews. And then we moved on to data extraction. So for the synthesis and analysis, we used the tool R for the meta-analysis and meta-regression. And as mentioned earlier, it was a single group meta-analysis for the adherence outcomes that we just looked at. And for the first one, so for the mean number of modules completed, we actually used the proportion because that would make it possible to compare across studies. So basically we divided the mean and the standard deviation by the total number of modules, and we basically got a proportion or percentage that we could compare. So just a quick summary of the included studies. We included 28 study groups. So some studies had multiple intervention groups, so they they were included multiple times. That's why we're counting the number of study groups. This shouldn't be a huge problem for the meta-regressions because we're not actually looking at participant characteristics, which means it wouldn't be there's no overfitting because we're using multiple groups with the same participants. Since we're only looking at study level and intervention level characteristics, that is not a major problem. So 28 study groups were included. Of those, 28 reported the mean number of modules completed, and that was the first adherence measure, and only 9 reported the percentage of completers of all modules. And even less reported, I think it was 2 studies that reported the percentage of completers of 80%, and one of them actually used the recommended dose. When we're looking at the predictor table at the bottom, I think the only interesting thing here is that there's a sufficient amount of observation per category or variable. Usually it's recommended to have the cutoff is around 8 to 10 observations per variable. And most of these, except for the global recruitment, meet the cutoff easily. Yes. So the results, so this is the forest plot for the meta-analysis of mean percentage of modules completed. So if we look at the results here, I think the highest adhering, the study with the highest adherence of this measure is Killock 2016, study group A. It has a proportion of completion of 80%. So 80% on average, participants completed 80% of the modules, which is pretty high. I can actually see that higher up, Brooks 2010 has 83% completion rate, and the lower end is around 30% or 0.3. And we can see the pooled proportion of modules completed is 0.57, which is, I think, a decent number. Again, since this is not effect size, we have nothing to compare it to. It's really hard to create any conclusions here, but that's okay since we're looking, since with our meta regression, we want to look at the predictors of adherence and not how high adherence is. Results of the second meta-analysis, so the percentage of participants that completed all modules. It's not a lot of study groups, unfortunately, and we can see that Johansson 2017 it has had a lot of participants. This is actually the only study that used the Amazon Mechanical Turk to recruit, so that explains the large number of people and not very high adherence when looking at this measure. So the overall pooled percentage of completers in terms of completing all modules is 47%. So for our meta regression, we actually used the first meta-analysis because it provided us with the numbers with the number of observations to conduct a regression analysis. And this meta-analysis is it just did not have enough study groups included in it. So let's look at the results of the meta-regression. Here we have all our predictors. So we have guidance, provided yes or no. We have the categorical guidance where we have two categories. We're comparing non-clinician guidance and clinician guidance. Here we can see that both guidance predictors are not significant. So there's actually no data that we were able to find to support what most other studies have reported, and that is that guidance is actually effective and increases adherence as well. Our meta-regression found to be a significant predictor is blended treatment. So again, if the treatment was blended, so if the online therapy was provided as an adjunct to some other form of therapy, some other form of treatment as usual, then it is a significant predictor of adherence. And the same thing goes for local recruitment. Intervention duration was not a significant predictor. So a few key takeaways. I think that guidance was not able to predict adherence was actually personally surprising to me. And it may be related to some other factors and the constellation of studies here. So because a lot of other studies have shown that guidance may be an important factor, and there's actually data to back that up, I think future studies are necessary to understand the exact mechanisms of guidance and how it actually could be used best to improve adherence. A lot of the studies that reported guidance and a lot of the experiments don't actually go into a lot of details. And I think the exact mechanisms are unknown to this point. Or at least the correlations, they haven't been looked at in terms of regression models. So if we look at our significant predictors of adherence, what are our conclusions? I think for blended treatment, that suggests that eHealth may be more interesting when it's provided as an adjunct to other forms of treatment for substance use. So maybe, and this is something that could be exclusively true for substance use, that standalone eHealth treatment may just not be enough. And another variable that may be correlated with blended treatment here is actually the severity of use. So it might be that participants that have a higher use than others may benefit more from blended treatment than others. So it would be useful to consider a stepped care approach here, where the participants with larger needs receive eHealth intervention as an adjunct, and participants that are not in such a critical stage receive sort of a self-help standalone kind of online treatment that could just be a first resort for them. So in terms of blended treatment, I think it would make sense that more studies compared these two types, so standalone versus blended treatment, to see if, to also understand the factors that may be at play here. There's very few studies. I think they're actually all on CBT for CBT. So it's a computer-based therapy of cognitive behavioral therapy. It's a very popular online treatment option for both substance use and mental health. And they looked, I think they've done this comparison, but it was just not enough to create any kind of review out of that or meta-analysis. Local recruitment, it was a significant predictor of adherence. And this really suggests that approaching participants through conventional methods, such as in person, at clinics may be more effective in keeping people interested and adherent to interventions. And here, more work is needed to really understand the factors that may improve adherence in local settings, and also understand why adherence rates are lower in global kind of settings where online recruitment is at play, and if there are correlations with the participant characteristics. Just a quick look at the limitations of our studies. This is probably a limitation you'll see in every review of adherence, is that there's just a lot of heterogeneity when it comes to reporting adherence and even the definitions of adherence. So a lot of the studies we actually came across in our screening and full text review phase had some sort of adherence measures, like number of logons, or very specific ones, like the number of pages visited within 3 minutes. But those were just, it was just very specific to a few studies and really hard to work with in terms of comparing adherence across many studies. So the best adherence measure we found was the mean number of modules completed. As I said, there's a lack of agreement regarding the definitions and how they measure it. Even though we met most cutoffs, the number of studies was still too small to make firm conclusions. So all the results should be treated very carefully. Another issue was in terms of the meta-regression. They included predictors. They may actually correlate with many other factors, and that is always the case. But we even had some in mind that we were, unfortunately, because of the data availability, we were not able to include in the meta-regression models. So one of them I mentioned was, for example, the severity of use when it comes to blended treatment. So people with higher severity of use may actually benefit more from blended treatment than compared to people with lower severity of use. But we couldn't really find a variable to properly map severity of use to some kind of data. And finally, and ideally, adherence should be looked at in terms of a dose-response relationship. And this is heavily discussed in the paper I mentioned, Sievering et al. 2017. But again, most studies do not explicitly define the intended use for their programs, and that is a big issue. Okay, thank you. Apologize, towards the end, there were more arms than words.
Okay.
Yeah, so.
Sorry,
yeah.
go ahead.
No, I just wanted to say that there was a question regarding blended treatment that I answered it in the chat, but just for everyone, blended treatment would mean that there's two components, one of them being the e-health component, which is usually an adjunct, but it could also be the main part of the program. But in addition, the users would receive some other form of treatment, which is usually some kind of conventional treatment form, like face-to-face therapy, or in case of substance use, could be substitution treatment or similar treatments.
Also, Farhad, in the WUWA chat, we have a comment from Amanda. She's saying that lack of internet access is massive for lack of rural access to virtual services. So I think that was a great comment about the data that they used and the data were collected. Probably they were from urban areas, I assume, right?
Yeah. So most of this data, or most of the studies that actually talk about access, they're mostly surveys. So we actually did, our lab did a survey in Egypt, and kind of did a comparison of the situation in Canada in rural areas and compared it to Egyptian rural areas, and how the access is actually, the issue of access is a similar one. But yeah, I haven't seen any analysis on how this could be a predictor of usage, because when we're talking about usage, we're already assuming that the participants have access to the intervention. So adherence, by definition, basically starts after access. So that is one issue why this variable is not really looked at in the adherence literature.
Okay, awesome. So we are nearing the end of our presentation. Is there anything else that you wanted to add as the closing remarks, Farhad, or that's it?
No, I think that's it. If anyone has any questions, feel free to email me. I don't know if I think the recordings will be uploaded at some later point. I'll make the slides available as well. And yeah, feel free to stay in touch, and thank you for listening in today.